Hello, everyone. Welcome to Asian Cancer Resource and Support Service Health Talk on Breast Cancer Update 2021 in this Breast Cancer Awareness Month. My name is Gemma Kim and I'm the Program Manager. Before we get started, I'd like to give you a brief overview of who we are and what we do. Asian Health and Service Center in Portland, Oregon launched new services to Asian community to address the full cancer continuum, ranging from prevention, screening, treatment, to survivorship support. We serve cancer patients and their family members in Cantonese, Mandarin, Korean, Vietnamese, and English as seen by our brochures here. Our goal is to increase the culturally and linguistically appropriate cancer resources, education materials, and support. To learn more about our services we provide, please visit our website. You are welcome to download our brochures in our website. We are also on YouTube channel, which we share many of our health talk presentation, cooking demonstration, and many more. Please feel free to check out our YouTube channel by typing Asian Cancer Resource and Support Service. With our presenters' permission, we also will be sharing this recording of a presentation on our YouTube channel. There are some housekeeping items. Today's presentation will be recorded for future training purpose. Please mute yourself when you are not speaking. We also will turn off your camera and audio to minimize background disturbance. Please type the questions in the chat box. We will collect the questions and have Q&A at the end of the presentation. Today's presentation will be uploaded to ACRSS YouTube channel. As a side note, our presentation is scheduled to run until noon today. However, our presenter will be staying until 12:30 to answer any questions. To improve our health talk, please complete survey, and we will value your comments and feedback. The link will be in the chat box and at the end of the presentation. I'd like to introduce Dr. Frances Ting. Dr. Ting earned her medical degree from the University of Kansas School of Medicine. She completed her residency at the University of New Mexico Health Sciences Center. She's board certified in general surgery. She has specialized in breast surgery since 2004. She has been a member of a cancer committee at the Adventist Health Portland since 2006 and has served as American College of Surgeons Cancer Liaison Physicians for Adventist Health Portland since 2009. She is committed to individualized care, patient education, and shared decision-making. She and her family enjoyed all outdoor activities in the Pacific Northwest. Please welcome Dr. Frances Ting.
Well, Gemma, thank you so much for that very kind introduction. And I'm very honored to be here today. I really wanted to thank Dr. Eric Zito for thinking of me when he asked me to present, and so I'm very honored to do that and really wanted to thank him. I've had the privilege of working with him and Dr. Chang for many, many years, so wanted to do a special thank you to him, and also Gemma, to thank you for all of your help over the past few weeks and for today, and thank you to Brian, who's in the background doing our technology help. So thank you so much. So this is a big topic, breast cancer, and it's very broad. So I really value Gemma's input as to kind of what to focus on and what you might really be most interested in. So I just want to provide a very, very brief overview and just kind of briefly review how we diagnose and treat breast cancer, and then wanted to focus on what's really new in current breast cancer treatment and thinking, and also to spend a little bit more time on survivorship issues. So I understand we have a few breast cancer survivors that had signed in or signed up for the talk. So really wanted to spend a little bit of time talking about that as well. So just a brief review, and I really didn't want to include a lot of numbers or data or really highly scientific or medical data. And if you all are interested in that, I can certainly provide references and additional information. So for breast cancer in 2021, this is still the most common diagnosed cancer in women. That doesn't mean it's the most common cause of death in women. It's still the most commonly diagnosed type of cancer. Fortunately, most cases are still diagnosed early. And as I'll just briefly talk about, a lot of that is due to screening mammograms. The good thing is when breast cancers are diagnosed early, frequently the prognosis is excellent. These are really treatable cancers, and we know that treatment is very effective. And so hopefully a lot of our women will continue to have a good quality of life after treatment. On the same hand, breast cancer deaths are also decreasing. This is, again, great news, mostly due to increased screening and also just improved treatments. Really, the kind of newest technology that's been out there on the horizon the last few years, and I'll spend a little bit of time talking about, is genomic testing. And this is really genetic testing of the actual cancer. This is not genetic testing of the individual, but of really testing the genes of the cancer. And this information gives us an idea of whether or not the patient really needs chemotherapy. And this has revolutionized current cancer treatment, because we used to think, wow, if cancer is already spread, if it's already in the lymph nodes, we might need to give everyone chemotherapy. And now with this new information, we're realizing that it depends on the type of cancer. A lot of cancers that are not as aggressive, even if it may have spread to the lymph nodes, we don't need chemotherapy. So this is really life-altering, life-changing treatment for breast cancer. So this is, and I'll talk a little bit more about it, but really this is what we're calling genomic or molecular testing of the cancer to find out who really does need chemotherapy. And with this, we're finding out more and more women don't. All right, next slide, please. Sorry for that. This is, we were just talking with Gemma that a lot of nice things about Zoom meetings. It's certainly more convenient and easier for a lot of people, but then sometimes it's nice to be in person too. And of course, all these little things that come up with technology. So I'm so sorry, I don't have control over my slides, but maybe I can pull them up and see. But I can just talk a little bit more, maybe. Oh, thank you. So I just wanted to include a slide specifically about breast cancer in Asian women, both immigrant and Asian American women. The incidence of breast cancer is actually lower in Asian women when compared to other ethnic groups, but this does appear to be increasing. Several factors have been looked at, perhaps a change in Western diet, maybe the foods that we're eating in this country, but it is increasing, but it is still lower than in other ethnic groups. Interestingly, the most common cause of death in Caucasian women is heart disease, not breast cancer. But in Asian women, the most common cause of death is cancer in general, not breast cancer, but just cancer in general. All right, next, please. Hopefully it will work. Thank you. So we owe a lot of early detection and improved survival in breast cancer now to breast cancer screening. And here, the goal here is really to find cancers in women early before they even notice they have symptoms of breast cancer, such as breast pain or a palpable lump. So the current recommendations for breast cancer screening, and I know this is a little bit controversial, and depending on which source you look at, there are different recommendations. But the current recommendations based on the American Cancer Society and the American Society of Breast Surgeons is to have mammograms once a year starting at age 40 for women of average risk. And what does average risk mean? That's no family history of breast cancer, no known breast cancer gene, no history of previous radiation. I mean, there are several other risk factors, but for most women, starting at age 40 every year. Some high-risk women may benefit from a breast MRI. And what is a breast MRI? This is a much more detailed imaging study. It's a much more involved study. And so most women won't need this for screening, but again, some high-risk women may benefit from that, and that's something that usually a primary physician would discuss. I do get asked a lot about how long should I keep getting mammograms? I mean, how old should I be when I stop? Really, there isn't a strict age cutoff. I really liked this answer. This was a consensus statement from the American Society of Breast Surgeons. And their recommendation is you can stop getting mammograms when your life expectancy is perhaps less than 10 years, because that seems reasonable. You hate to give a cutoff saying like at age 70, we should stop, because age 70, depends. And many people might by physically age be 70, but really be very healthy. So I think I like this recommendation about life expectancy. Next, please. And just to kind of go on, once I wanted to kind of just go over just briefly how we diagnose breast cancer. And the first step usually is the screening mammogram. The screening mammogram, again, ideally would look for something before we even know anything's there. Oh, here. So what is a mammogram? It's basically just a low dose X-ray of the breast. And right now, it's still the best screening test that we have. I do get asked a lot about concern for exposure of radiation. And what I will tell people is that the dose of radiation from a mammogram is about equivalent to the amount of radiation you would be exposed to from a plane ride from LA to New York. So it is a dose, but it is a low dose. And I know that many women have been concerned about that exposure, but it's a small dose and it's still our best screening method. Okay, next slide, please. Let's see. Following a mammogram, if there is a suspicious finding, we would normally follow that sometimes with another mammogram, and that would be called a diagnostic mammogram. And what that is that's just that would look more specifically at the area of concern. Many times if something shows up on the mammogram, it might be okay. It might just be an area of dense breast tissue. It might just be the positioning. So if we do another mammogram that's just looking at the focused area, sometimes that finding goes away. If it doesn't, if it persists, then we would usually go to another study. And the next one we would typically order would be a breast ultrasound. And that's a different type of technology. It's not an X-ray, it's using sound waves. And that kind of gives us a better picture of what is going on in the breast. It looks at the outline. It looks at the difference between the tissue texture. And if the slides work, I have some examples of what ultrasound looks like as well. If the ultrasound does confirm that there is a finding, okay, it looks like, okay, we can back up here. So yes, this, I think slide 11 would be the next one. Thank you. So this is just to say what to expect during the mammogram. And many of you have probably already had one, but as you can see, there are generally two views. One is kind of the pancake view coming up and down, and the other is from the side. Okay, next slide, please. And, you know, I always get asked about breast density on mammograms, and a lot of women say, you know, they've always told me my breasts are really dense on mammogram. What does that mean? Really, breast density just it correlates mostly with age and with estrogen exposure. So starting on the right of the screen, extremely dense, this is probably a premenopausal woman, or perhaps a postmenopausal woman that's taking estrogen replacement. So it's just really the amount of estrogen stimulation that makes the breast tissue look more dense. So generally, postmenopausal women, if they're not on estrogen replacement, they would look more like on the far left of the screen. And mammograms are easier to read when the breast tissue is less dense. So just because the tissue is dense does not mean it's abnormal. Again, it has to correlate with amount of estrogen exposure. And this is why mammograms aren't perfect either, especially in younger women. Okay, next, please. So going back to what if the first mammogram is abnormal and you get a letter saying, oh, we've seen something there, we want you to come back for more. And this is what I was saying, we'd have you come back for a diagnostic mammogram. Well, most of the time, an abnormal mammogram is not breast cancer. It could be, like I said, maybe just an artifact, maybe difference in positioning, maybe a difference in texture of the breast. So that's why we would get another mammogram. And this is the diagnostic mammogram. It would be focused just to kind of look at that specific area of concern. If that does persist, then I was saying we would go ahead with a breast ultrasound. And again, that's looking just at that focused area. It's a very targeted exam. And it's a different technology. We don't want to get a third mammogram. We're using a different technology using sound waves. Sometimes we would get a breast MRI. Again, this is such a specialized test. It's really in certain circumstances. And if we're seeing something suspicious on mammogram and ultrasound, then that's when we proceed to the next step to get a biopsy. Next slide, please. And a biopsy is actually when we're taking a sample of the tissue to look under the microscope to really tell us what this is. Because again, sometimes what we're seeing might not be cancer, but the only way to really know this would be to actually get a tissue diagnosis. So same thing if you actually feel a lump. If you feel something in the breast, we probably would do the same things as if you had an abnormal screening mammogram. Again, we'd repeat with another more focused mammogram, get the ultrasound, maybe a breast MRI sometimes, and maybe the biopsy. Okay, and next. So this is just a picture of what an ultrasound looks like using sound waves. It's using the probe. Next slide. And images. So I don't need to talk about every single image, but basically an ultrasound right away can tell us if this is a cyst, if this is a fluid-filled mass, which almost always is okay, or maybe it looks like a solid tumor that's still not cancer because there are some benign tumors in the breast. Or is this a solid tumor that does look more suspicious for cancer? And so that an ultrasound gives us specific information that, in addition to what the mammogram would provide. Next slide, please. Just very briefly, so the breast MRI, much more detailed imaging, and it looks at both breasts. Right now for screening, we're only recommending this for women with a known breast cancer gene, women with a very strong family history of breast cancer. Sometimes if we need more information about certain types of cancers, and sometimes can help with surgery planning. Next slide. And this is just to kind of show you what an MRI, it's more involved because you do get an IV and there is contrast that's given, and it's kind of in that little tunneled machine. You're laying face down with your arms above your head. It's definitely more involved, so we don't just order this on everyone. Next slide, please. So a biopsy is actually taking a sample then. If we've seen something on imaging we're concerned about, we want to find out what this is, we've got to take a sample of the tissue, look under the microscope, and then that's the most definitive way of getting a diagnosis. The preferred way to do a biopsy is what we call an image-guided. We're not taking someone to surgery to do a biopsy because we really just want to get a diagnosis. So the preferred way is to do an image-guided biopsy. This is less invasive. It's not going to the operating room. It's not an operation. It's typically done in the radiology suite. And the preferred way to do a biopsy is under ultrasound, just because it's easier. You don't have to go back in the mammogram machine. The probe is put back on the breast. We find what area we saw before, take a needle device, take a sample of tissue. Sometimes, however, there are certain types of cancers that we don't see on ultrasound. These are typically very early, and we might see this finding only on mammogram. And if that's the case, then the biopsy does have to be done with a mammogram machine. So this one is a little bit more complicated. In the next slide, I'll show you some pictures of both ways. Next slide, please, if we can. It's just through if the biopsy has to be done under a mammogram, it's a little bit more involved. There's a special table that you have to, oh, this is it, thank you. So on the left, it's a special table that shows you have to lay down and your breast drops down and you get another x-ray. So obviously this looks a little bit more uncomfortable, not as easy. And on the right, it shows you how we can do the biopsy under ultrasound. You can find it easily, you're much more comfortable, and you can actually watch this being happened as it happens on the screen. And it's under direct visualization, the needle is advanced into the lesion and a sample of tissue is taken. Next slide, please. So just a little bit about the biopsy report. What are the different things that this could show? Well, first of all, it could be a benign lesion. It could just be a cyst. It could just be a benign tumor. It could be what we call either a lipoma, which is a benign fatty tumor, or a fibroadenoma. That's another benign tumor. So not always anything that we have to do anything more about. It could be a high-risk lesion. What does that mean? The most common diagnosis there It's called atypical ductal hyperplasia. Those are a lot of very fancy words, basically just meaning some abnormal cells there. And what that tells us is, okay, if we see this, then you're at higher risk for developing breast cancer, but this isn't cancer. The other thing it could be on your biopsy could be what we call ductal carcinoma in situ. Those are very fancy words. We sometimes call it DCIS for short. Sometimes I even like to think about this as precancer. These are cancer cells that we found in the breast, but at this point, they haven't formed a lump and they haven't spread anywhere. They haven't broken through the tissue in the breast. We most commonly see this as microcalcifications on a mammogram, little white dots. Because this is so early, there's no lump there. So frequently, DCIS will only be seen on mammogram. And so that's a time when the biopsy would typically be done under the mammogram for calcifications. Or, the biopsy report could come back showing breast cancer. The more we know about breast cancer, the more types we seem to be learning about. The most common type is called invasive ductal, and ductal has to do with the type of cell in the breast. There's actually breast cells that produce milk, and those are called lobular cells. And then there are the ducts, the little tubes that carry the breast milk from that breast tissue up to the nipple. So invasive ductal carcinoma, this is the cancer in those ducts, in those little tubes that carry milk up to the nipple. And that's the most common type. The other type is, invasive lobular. These are breast cancer cells in the actual milk producing breast cells. And that's not as common. There are other less common types. Some are less aggressive, some are more aggressive, but most cancers fall into either one of those two types. Next slide, please. So back to DCIS again, this is what I call precancer. The cancer cells haven't spread beyond the breast tissue. We still treat it like a true breast cancer, like an invasive breast cancer, meaning, invasive cancers could spread. So we do treat it the same. And why is that? If we don't take care of this, then over time, this could develop into a true invasive breast cancer. Next slide, please. Going back to invasive cancer. So now these are cancers that do have the potential to spread throughout the body, leave the breast tissue and go through the rest of the body, either through the bloodstream or through lymphatics. We've really started classifying breast cancer as to different subtypes, and these have to do with different receptors. So not to make this too confusing, but most breast cancers are what we call estrogen positive. And estrogen, of course, is a normal female hormone. We also will test for progesterone, another normal female hormone. Most breast cancers in older women that have a good prognosis are hormone receptor positive, meaning both positive for estrogen and progesterone. And this is really a good prognosis. And why is that? Well, what the estrogen and progesterone positive breast cancers, what that means is that normal female hormones in your body help your tumor grow. But why does that sound good then? Because it doesn't sound good at first. Why is that good? Well, it means that if we know what helps your cancer grow, we can block that. So if your breast cancer grows in response to estrogen, we can block it. We can take it away. And so that's good. That means we can still kind of control the growth of that cancer. We only need to block the estrogen. We don't need to block both. And the reason is if we are able to block the estrogen, then the progesterone will be blocked as well. It has to do with the hormone pathway. So even though we check both hormones, Really, we only need to block the estrogen. The other receptor we look at is called HER2, and this is a growth receptor. About 20% of all breast cancers are HER2 positive. This is a faster growing, more aggressive cancer. We do know how to treat it. It is also very treatable, but it is definitely a more aggressive type. There is another very specific type of breast cancer called triple negative. And that means all three receptors, estrogen, progesterone, and HER2, all three are negative. This is a very, very specific type of breast cancer. Again, also treatable, but more aggressive. And very rarely there's an inflammatory breast cancer. Again, this is a very specific type of cancer, also more aggressive, but has a known treatment protocol. Next slide, please. But most breast cancers in older women, and by older I mean postmenopausal, even greater than age 70, most of these cancers are early stage and estrogen positive. So most of these cancers are treatable and have an excellent prognosis, and many will not require chemotherapy. Next slide. So once we have a diagnosis of breast cancer, always the next question is, has it spread? Has it gone anywhere? And how would we know if it has? Well, the first place breast cancer would spread to would be the lymph nodes under the armpit on the same side. And if we find that cancer is in those lymph nodes, then there's a higher chance that the cancer cells have gone elsewhere. Next slide, please. If we think, okay, it is in the lymph nodes, we found that out, and I can talk about that a little bit later in the surgery slides. How do we know if it's gone through the rest of the body? We would do certain imaging, could be CT scans, could be a bone scan. If it has gone to the body, common places would be to the brain, to the lungs, to the liver, or to the bones. And how would we know this? We could look at imaging, we could look at symptoms. If it is perhaps in a later stage, there might be symptoms of seizures. There might be symptoms of back pain or joint pain or abdominal pain, shortness of breath. There might be symptoms that would prompt us to really look into this closer. Could breast cancer that's spread throughout the body still be treated? Absolutely. Typically, if we find that it is what we might call stage 4, meaning there is cancer spread throughout the rest of the body, we wouldn't start with surgery. We would probably do a combination of chemotherapy, radiation, or other medicines. And the goal being that we really don't want to make your quality of life more miserable with the treatment, but want to control the spread with as few side effects as possible. Next slide. Which doctors would I see? You have a team and it gets overwhelming. A lot of people will tell me, I have so many doctors, I have so many appointments. Hard to keep track of everything. But typically you will see a surgeon, could be a breast surgeon, could be a general surgeon. You would also see a medical oncologist. This is the doctor that would talk about medicines for breast cancer, and if you needed it, chemotherapy. And there's oftentimes a radiation oncologist involved as well. I'll discuss all the roles in the later slides. Next, please. Really important to other healthcare providers that can be part of the team that add value as well. Most programs now have a breast cancer nurse navigator. Excellent role. Again, really overwhelming. New diagnosis of cancer, so many different doctors, so many different options of treatment. This is someone who can really kind of integrate everything, help with support services, kind of make sure that you understand the role of all the different providers. Really invaluable person, can refer for support groups. I know I was just talking with Gemma that most of the nurse navigators are aware of the Asian Cancer Resource and Support Services and have referred a number of patients to the center. A physical therapist, absolutely important for recovery from surgery, and I'll talk about that a little bit later. Social workers can also be very, very helpful. Of course, there are financial concerns with a diagnosis of cancer. There are all sorts of hurdles with insurance and who covers what and what benefits, and it can be very overwhelming. There can be financial assistance. There are programs out there. There can be help with getting transportation to doctor's visits, and a social worker frequently can help with these issues. And most programs do have social workers, and I'm sure that the Asian Cancer Resource and Support Services can help with these services as well. Next, please. So treatments could be some or all, a little mix of all of these: surgery, medication, including chemotherapy in that category, radiation. I'm not going to delve in the details of complementary medicine just because it's out of my expertise, but absolutely, I get asked a lot of questions about patients. Can I also get acupuncture? Can I see a naturopathic physician for different herbal medications? Absolutely, I highly encourage that as well. Next slide, please. So this is obviously the area that I know best is surgery and different options. Traditionally, of course, we only had the option of a mastectomy, which is removal of the whole breast. This is always an option, but many times not necessary. When is it necessary? Maybe if it's a really large tumor. Maybe if the nipple is involved. Maybe if we find out there are two cancers in the same breast, and then we would want to probably remove the whole breast. There is an option of reconstruction. I'll go into more detail with this option later on. But then there's the option of a lumpectomy. And of course, this is more ideal because it's less invasive. It's not removing the whole breast. It's just removing the area of breast where the cancer is. Most of the breast is left intact. This is obviously quicker recovery. It's an outpatient surgery, cosmetically more desirable as well. There are a couple of things that are very particular to a lumpectomy, which I'll discuss in detail, but most women, and here's our goal, right, of screening, is to find these cancers early and they're small so that we allow for more lumpectomies to be performed rather than a mastectomy. Going back to that question, has the cancer spread? Did it go to my lymph nodes? Part of the surgery also can involve what's called a sentinel lymph node biopsy. This means we want to check the first lymph node or group of lymph nodes in the armpit. We want to see, has the cancer gone to that first lymph node? And that's called the sentinel lymph node. And there's a slide a little bit later I'll show you that I'll talk about that as well. And then frequently I will get asked about surgery on the other side, especially if someone is more interested in a mastectomy. And I will get asked about, well, should I have bilateral mastectomies? Should I remove both breasts? Is that the most aggressive method? Is that the best choice? For now, which I'd like to, one of the main points of what's new in 2021 is really, again, talking about what kind of cancer is this? How aggressive is this? The new genomic testing can tell us, boy, this cancer, we don't really think has a high chance of coming back in your body. Or, maybe because you don't have other genetic factors, you don't have any other high risk factors, probably we're not so concerned that you'll have a risk for another breast cancer, for a second breast cancer. So for now, what I will tell women is that most women do not benefit from a prophylactic mastectomy, meaning we're doing a mastectomy on the other side before there's cancer there. Most women will not benefit from this. And the data show us that there's no improved survival. But having bilateral mastectomies is a bigger surgery. So there's definitely an increased risk of complications. But for now, unless there's a strong family history of breast cancer and that we know you have a breast cancer gene, for most of us, there's no survival benefit for a prophylactic mastectomy on the other side. Next slide, please. And I think I have just a few pictures of the different types of surgical options. And I might move a little bit faster just because I do want to get to the survivorship issues. So just quickly, pictures of the lumpectomy. Again, we're not removing the whole breast. Really, minimize the scar, minimize the amount of injury, and just removing the area where the cancer is. And then the other little skin incision you can see in the picture on your left, in the screen left, is that where in the little incision would be made to check the lymph nodes. Next slide. So for a lumpectomy, really, this is very important to get what we call clear margins. I'm not removing the whole breast. So if we're just removing the area where the cancer is, we want to make sure we're all the way around it. So this is just showing a picture. What's a negative clear margin? What's a positive margin? Well, we see cancer going up to the side. So with a lumpectomy, it's great. It's faster recovery. It's an outpatient surgery. But there's a chance, if we don't get a clear margin the first time, we might have to go back and take additional tissue. Next slide. This is just showing kind of the little pictures about a sentinel lymph node. Why do we not want to take a lot of lymph nodes out? One of the biggest complications from breast surgery is lymphedema, which means swelling of the arm. And this results whenever we remove lymph nodes. This is something we really want to avoid at all costs. So if we're checking lymph nodes at all, we really just want to find the first node or group because they're clustered like grapes. I usually end up taking about 2 to 5, find 2 to 4, something like that. But we really don't want to take out a lot because of this risk of lymphedema. So there is a way to identify that first group of lymph nodes. And so that's really only what we're trying to remove. Next slide, please. So going back to a mastectomy, it's an option. We don't have to do it, but it's always an option. Obviously, it's cosmetically not as desirable. It's a bigger surgery. It's more injury. It's longer recovery. There's an option of reconstruction, or there's a movement right now called going flat for women that are choosing not to have reconstruction. And again, this is a very personal decision. Next slide. So reconstruction is not easy. It's typically staged. Involves a couple, maybe 2 or even 3 additional operations. So it's definitely more complicated. It's absolutely advantageous for body image. And these are just showing you some pictures of where the scar would be. Next slide. Typically, the most common type of reconstruction is with an implant, just because it's easier than, I'll show you another slide for using your own tissue or muscle flaps. Next slide, please. So here's just briefly implant. They're typically placed behind the muscle of your chest wall. And why behind the muscle? Because if we place this right behind your skin, over time the skin stretches and the implant can move. So it really has to be placed behind the muscle so that it doesn't move. But right now, there's no space behind your muscle. So typically, reconstruction with an implant is staged, meaning the first time, at the time of your mastectomy, the plastic surgeon would put what's called a tissue expander behind the muscle to kind of create a space there. And over the next few months, gradually the expander is filled, creating that space for the new implant. And then you would have at least another operation to remove the expander and put the implant in. So it is a foreign body. It does have a higher risk of infection. it is staged. Next slide, please. Other options for reconstruction are what's called autologous flaps, meaning you're using your own body tissue to recreate a breast shape. And most commonly, that's with a muscle called the latissimus dorsi, and kind of in the side and the back there that you can see on the left. And on the right, sometimes we use a muscle flap from your abdominal wall. These are much, much bigger operations. They take much longer, higher risk of infection or not healing, and definitely longer recovery. But the advantage is it's not a foreign body, it's your own body tissue, and frequently the appearance is much more natural as well as the feel of the tissue. Next slide. So recovery, this is, makes a big difference. A lumpectomy is an outpatient surgery. Basically, I have you wear a sports bra and restrict upper body movement for, 1 to 2 weeks. Mastectomy, overnight stay in the hospital at least, could be longer if there's reconstruction, and a much longer recovery period and more activity restrictions. Typically, you'd also have a drain in for maybe 7 to 10 days. With reconstruction, that recovery could stretch out to maybe 8 weeks or even 12 weeks. Next slide. After surgery, sometimes before, you'd have to meet with a medical oncologist. This is a cancer doctor that talks to you about medicines. Going back to that estrogen type of breast cancer, this is the kind that we really are happy about. This is the one that responds to blocking estrogen. So there's different types of estrogen blockers, and the medical oncologist would definitely talk about what would work best. They do have side effects, and we'll talk about this in relating to survivorship issues. Next slide, please. So just kind of briefly, estrogen has so many different effects on different parts of the body, and they all seem like they're not related. But when we block the estrogen, what happens? Sometimes you might feel joint pains. A lot of women feel those menopausal symptoms, hot flashes, night sweats. Unfortunately, estrogen does help in bone health. So when we block it, you could have loss of bone density. And this also relates to, more joint pains. It also can affect vaginal dryness. And many women will choose or have the option of using an estrogen cream to help with this. And you might say, what? We're blocking estrogen in your body. Why are you talking about an estrogen cream? Well, what that can do is since it's topical, it really has very, very little systemic absorption. So where we want to block estrogen through the whole body, if we're just talking about a local area just to help in some tissue in that area, most of the time an estrogen cream is okay and can help with that. Next slide. Sometimes some cancers require chemotherapy. These are those IV medicines that treat your whole body. And of course, you're given through an IV, either through a vein in your arm or sometimes a port could be placed. Next slide. When would I need chemotherapy? Different cancers. We talked about the estrogen negative or the triple negative type, or the type with HER2, that growth factor. Those cancers, they're more aggressive. And typically we would offer chemotherapy for those types. And sometimes we would do that even before surgery. I had talked earlier about our 2021 update. This is genomic testing. This is genetic testing of your cancer. And this tells us, do you really need chemo? Right now, the two most common tests are called the Oncotype DX and the MammaPrint. These are both generally ordered by the medical oncologist. Next slide, please. Side effects, of course. Since chemotherapy doesn't target actual cancer cells, chemotherapy is targeting all the cells in your body that are rapidly dividing. So unfortunately, that means hair cells. That means fingernail cells. That means cells in your tongue that are taste buds. So all of these symptoms result in, nausea and vomiting. Those are the cells lining your GI tract. Hair loss, unfortunately. The blood cells that are produced in your bone marrow. resulting in anemia, higher risk for infection, and of course, overall fatigue. Next slide. Just very briefly, there also is an immunotherapy for certain types of breast cancer. This is using your own immune system, much fewer side effects than typical chemotherapy. Next. And this is, again, I'll kind of start going through these a little bit quickly just to get to survivorship issues. Next slide. Sometimes after a lumpectomy, radiation might be recommended, and usually that's just to treat the rest of the breast. If we didn't remove the whole breast, then how do we treat the rest of the breast to make a lumpectomy as effective as a mastectomy? Well, then sometimes we would add radiation to just treat the rest of the breast. Our 2021 update, more and more women we're realizing do not need radiation after a lumpectomy, especially if it's the estrogen positive type and if they can take an estrogen blocker. And then we're realizing that there's not any survival benefit to radiation. Next slide. This is typically what a radiation room would look like with the radiation machine there. Next. Different positions for radiation. Next slide, please. Side effects. Almost everyone from radiation shows a sunburn on the skin of the breast and chest wall. This does heal, but sometimes this is really troubling. Can result in peeling of the skin or blistering and pain. Sometimes the entire breast is swollen and feels very heavy. This tends to be more in larger breasted women. Obviously, there's just more breast to target and higher dose of radiation. Towards the end of radiation treatment, most people feel pretty tired. Most of the time, radiation is given small doses every day, Monday through Friday, for 4 to 6 weeks. So at the end, there's definitely some fatigue there. There could be a long-term risk of injury to the lung and to the heart. Long-term after radiation is completed, sometimes the breast shrinks, it can feel more firm. Sometimes there's nerve damage in that same arm, creating numbness. Sometimes there's a risk of lymphedema, even if we didn't remove a lot of lymph nodes. And that's the swelling of the arm. Again, long-term, perhaps injury to the underlying heart or lung. Sometimes, rarely, a second cancer could be caused because of the exposure to the radiation. Next, please. So really, I wanted to focus on survivorship because more and more women are surviving breast cancer. So then we really need to focus on what are the long-term effects of cancer treatment. What are these important things to deal with survivorship? So what is survivorship? This is, having really no signs of cancer after treatment. This also involves what's important to quality of life, living through and beyond your cancer treatment. This is different for everyone, and certainly a range of emotions. Some women may feel intense joy. I'm done. I'm a breast cancer survivor and feel stronger than ever before. A lot of relief, but sometimes people can feel guilt. Some women feel anxiety or fear, like I can never let go of the fact that my cancer might come back. Next, please. So lots of current research and effort looking into survivorship and coping. And I think always the most important thing to do is acknowledge. Always acknowledge that this is difficult. This is tough. This is a challenge. It's not easy and it's overwhelming. Always acknowledging a feeling, I think, is the first step to getting better. Thinking through solutions. This is emotional. And I will see a lot of women who come in and the first thing they want to do, you know what? Just take them both off. I want bilateral mastectomies. Thinking through, understanding the biology of breast cancer. Okay, look, maybe I don't need to be that drastic. This is a type of cancer that I can treat pretty easily. Maybe more surgery maybe isn't better. So even though it is emotional, to not be as emotional when we're thinking about treatment options. Support. Always ask for and allowing the support of others, friends, family, support groups, other peers, other breast cancer survivors, Asian Cancer Resource and Support Service, Huge, lots of resources out there for women. And last, I really feel this is important, feeling comfortable with the course of action you choose. So many times I'll also see women years later, oh, maybe I should have done a mastectomy. Maybe I should have had the lumpectomy. Maybe I should have had reconstruction, or maybe I shouldn't have had reconstruction. You can only choose what's best for you at the time, and go easy on yourself. No one has a crystal ball. No one knows what to expect in the future. No one knows, oh my gosh, okay, you're not going to have a recurrence. You're going to be fine. Oh my goodness, you did have a recurrence. No one knows. So always you have to feel good about your treatment choice, your decision. And I tell people, you do this for you. You don't do this because your husband wants you to have a mastectomy or not have a mastectomy, or your daughter or your son or your friend. Someone might say, you know what, this is what I did, but you're your own person. Everyone's different. Everyone's breast cancer is different. So I think really, really important to always feel good about what you decide, and that decision is yours. Next slide, please. If that works. But I will hear this frequently. And the other thing I tell people is I want you to believe in your treatment. And on the other hand, you know what? I have people say, what if I decide not to have radiation? What if I decide not to take the medicine? And I always say, absolutely. Again, this is your choice. No one can go through this treatment except for you. If the side effects are terrible, it's not worth it. But here's survivorship issues. So we were talking about those estrogen blockers. Bone health, absolutely. It reduces bone density. And joint pain. I had one woman come in, she said, my hands hurt so much. I can't even pull the comforter up when I'm in bed at night. That's terrible. That's not worth it. If you can feel good about, saying, you know what? I don't want to take this. I don't want to live the rest of my life like this. My quality of life is important. I think I'll stop and be able to pull up the comforter in my bed, be able to do things with my hands and be okay with that. 100% agree and support that. Changes in your body image after surgery and radiation. We kind of talked about there's scarring. There could be scarring. There could be firmness. There are certain adjustments to make regarding how your body looks and feels. Cognitive function. Sometimes after chemotherapy, it's called that chemo brain. Difficulty with concentration. Difficulty with memory. What can we do about this? There are newer and newer programs from occupational therapy that have to do with cognitive therapy. Helpful. Things are out there. Emotional distress and depression, of course. Again, this is not easy, not an easy journey. Lots of support that we can help, individual therapy, again, support groups. Fatigue, difficulty sleeping, fear of breast cancer recurrence, that's a big one. A lot of people say, how can this is always over my head the rest of my life. Will this come back? How do you deal with that? How do you cope with that? Financial issues. This goes back to, involving perhaps a social worker early on. Sexuality, intimacy issues. Again, like I briefly talked about, there's vaginal dryness with taking an estrogen blocker. How can we help with that? Weight gain. Unfortunately, that's another side effect sometimes long-term of the estrogen blockers. And spirituality, finding meaning. A lot of women come in and say, you know what, this has made me stronger. I want to find meaning in this because I've gone through this. I want to help others now. This is, an important aspect in kind of resolving the whole journey. Next slide, please. Quality of life, so important. As I was saying, if some of these treatments are affecting your quality of life, can you stop? Absolutely. But what can we do to help? So almost always exercise, right? Can improve mood, fatigue, social well-being, moving your body, just even going for a short walk. But absolutely exercise has found to be very, very crucial in overall well-being. Social support, of course. Again, support groups with peer groups, other survivors, Asian Cancer Resource and Support Service. Wonderful, wonderful service there. Individual counseling can help. Some women find like, I've gone through this. I want to help others. So being a mentor to others that are going through this. Volunteering. Of course, there's, once our world goes back to normal, there's the Komen Foundation, there's the Race for the Cure, there's, American Cancer Society events, multiple events out there. Meditation and breathing techniques. So helpful. And can be taught by either therapists, can be self-taught. So many apps out there even now that encourage this. Next slide. Just wanted to briefly mention cultural beliefs about breast cancer, especially in the Asian culture. Lots of beliefs about stress. I get asked that a lot. Currently I have a lot of stress at work, family stress. Could this have been involved with the breast cancer? And I always think, absolutely. Stress just affects your body, affects the way your body is able to fight infection, to fight off naturally occurring cancer cells in your body. Because we think sometimes cancer just happens, but most of the time our body recognizes those cells and can kill those cells before they become a problem. So our body, we have natural barriers and ways to fight this. Can stress affect that? Absolutely. Lifestyle. A lot of people think, will come and ask, I'm not sleeping as well. My diet habits, I'm not exercising. Could this be related to the cancer? Everything could be related. And now that the more emphasis on survivorship, what can we do? Exercise, we can change diet, we can involve meditation, all of these things to try to help the stress cycle. One thing I've often seen in some Asian patients is this fatalism, this belief that, this was just going to happen and nothing I could have done to prevent that. And always, I think, going back to that spirituality, maybe finding meaning in this, maybe trying to help others. I think part of coping is, again, finding some meaning through the suffering, through this journey. Next slide. So what's new? I'm so sorry I'm running out of time, but really the trend is to minimize therapy, less surgery. We're finding out, again, we're trying to push lumpectomies over mastectomy, right? More surgery, not necessarily better. What about lymph nodes? Actually, now we know that we don't have to take a lot of lymph nodes. Sometimes we don't even have to sample them at all. What's the benefit there? Avoiding the risk of lymphedema. Some people even say, well, what do I even have to have surgery at all? And this is a great question. Going back to this estrogen positive breast cancers, we can block them with the estrogen blocker. So I even have some women who can't have surgery for whatever reason. They have bad hearts, they have bad lungs, they're wheelchair, in a wheelchair, they're confined to a wheelchair. They physically can't have surgery. If they have an early breast cancer that's the estrogen type, we might just put them on the estrogen blocker for the rest of their life and never need surgery. Next slide. We're trying to say less radiation. If it's postmenopausal older women, we're finding out women over age 70, if they have an early breast cancer, that's the estrogen type, that they can be on an estrogen blocker. No survival benefit for radiation. We don't need to give radiation. Next slide. Less chemotherapy. So how do we know who really needs it? We're going to test every cancer. Not every cancer. If it's clearly an estrogen positive breast cancer, we probably don't need to test because we know we can give an estrogen blocker. We don't need chemotherapy. But for other aggressive cancers, or if a cancer has already spread, we can definitely check the genetic profile to say, is chemotherapy necessary, and even how much chemotherapy? Do we still have to give the really tough guns? Can we give something a little bit easier? Do we have to give as much? So the trend really is to do less. Quality of life, so important. Let's do as much therapy as we need, but not interfere with the quality of life. Next slide. So our overall trend, minimize therapy. And there's a great campaign, great movement called Choosing Wisely. This is not just cancer, but it's this movement throughout medicine to, just because we have the technology doesn't mean we have to do it. What is really reasonable and necessary to do? Next slide. So again, I'm sorry that I ran a little bit over time. I really wanted to allow time for questions. Again, thank you so much to Dr. Zito for inviting me to talk. Gemma, thank you so much for your help with the slides and your feedback. And thank you to Brian today. Of course, thank you to the Asian Cancer Research and Support Services just for being here, for all you do for our patients. Thank you so much.